Yeah, so today I'm going to talk about person-centered infection prevention or resident-centered infection prevention, whichever way that you'd like to refer to it, but either way, it is basically person-centered infection prevention. Next slide, please. Okay, this is just disclosures. I have no disclosures. All right, so today we're going to really define what person-centered infection prevention is about, the two main components of person-centered infection prevention. And then, summarize the principles of residents' rights and engagement in preventing infections and controlling infections in nursing homes. And of course, articulating the major lessons learned from the application of person-centered infection prevention. Next slide. All right, so when we think about infections and preventing infections in nursing homes, so before we even had COVID of 2020, we know that there was an ongoing issue, unfortunately, with the majority of nursing homes and facilities and long-term care facilities in the United States. 82% of nursing homes in the United States had been cited for an infection control violation. 50% of those had repeat problems. And then, of course, before the year before the pandemic, there was 1.6 million to 3.8 million infections per year that were being reported. So it was an ongoing issue. This wasn't, something that just happened because of COVID, right? We've been having, unfortunately, issues with infection prevention and healthcare associated infections in nursing facilities for a while. So then, of course, we know COVID hit, the COVID era, where COVID-19 came in, and on top of already having infection issues, we also, there's an estimated almost 600,000 infections and almost 120,000 deaths due to COVID. And then there was, on top of that, an additional 40,000 excess deaths that weren't attributed to COVID-19, but due to maybe neglect or abuse or other issues because of restrictions that were put in place due to COVID. Of course, those severe restrictions, those waivers, of course, they impacted nursing home residents. There was restrictions of visitors, restrictions of advocates, there was restrictions of certain caretakers. And of course, there was a suspension of surveys, waivers on staff. All of these, of course, unfortunately, just snowballed into creating ongoing issues with infection prevention. Next slide, please. So, obviously we know that, it's no surprise, right? We all felt the huge impact of COVID and the pandemic on infections and their spread. And of course, how it really had the huge impact in nursing facilities. And of course, a lot of these, the greatest impact, we talk about infections, and yes, infections are important, but of course, it was also a huge impact because of the suspension of all the basic rights to all of the basic residents' rights, which led to decline in their overall nursing home residents' overall decline in their physical, social, and mental health. And so again, it unfortunately snowballed into an even bigger issue. And it highlighted a lot of gaps and a lot of opportunities that we have in order to strengthen those. Because this is not going to be the first time this wasn't the first time that there were outbreaks, and this is not going to be the last time that we're going to have something. Hopefully nothing like the scale, but that is going to have a potential impact due to infections and their spread on the physical, social, mental health of nursing home residents. Next slide, please. So, what is person-centered infection prevention? What is it? How do we define it? We really think about infection prevention that really empowers and engages people to promote and practice infection prevention control in an environment that respects the rights and roles of residents and their advocates. That is really what it's all about. So you see here bolded, it's about empowerment, it's about engagement. When you have engagement, you have empowerment. And it really focuses, again, on respecting the rights and the roles that residents and their advocates can play in preventing infections. Next slide. And we have these different definitions of what patient family-centered means. The Institute of Medicine said it provides care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. They put this out there really for all sorts of settings, and not just nursing facilities, but all different type of clinical settings. And then the Institute for Patient and Family-Centered Care states that patient and family-centered care is an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships. Of course, that's very important among healthcare providers, patients, and family, and it redefines relationship in healthcare. And I think that, when we think about how we can really be more resident-centered, more family-centered, it really does go down to, making sure that there is a mutually beneficial partnership amongst residents, their families, the advocates like ombudsman, and of course, nursing home administrators and staff. There is a way that we can have a good mutual partnership so that in the end, we do have, effective infection prevention control. All right, next slide. And I think that a lot of nursing facilities have been dealing with this issue because there was, as I mentioned, there was a lot of suspension. You guys know, a lot of suspension of laws and regulations when it came to person-centered and resident-centered care. And now we're kind of at this point where they're being reinstituted. They have been reinstituted, and now how do we make sure that that we do provide precautions that per CMS and per state law state that precautions should be the least restrictive possible for the resident based on his or her clinical situation. That's always so difficult because sometimes I know when I went out in the field and we would do an outbreak, there would be an outbreak in a nursing home, we would be called out because of the state. We would go as epidemiologists to give information on how can information and guidance on implementing infection control measures. That was always the problem, especially if it was a multi-drug resistant organism, where basically we said, well, the guidelines is to indefinitely just put people in isolation, which is, just didn't work, right? It wasn't, it really didn't meet this definition. There's always kind of this balance to make sure that, you are protecting other residents from infection, you're protecting that person, but also making sure that things are the least restrictive possible. And that's where it does get difficult. And that's where you really have to think about residents' rights and engagement. Next slide, please. So when we think about the residents' rights and their role in infection prevention, obviously residents have the right to be, there's three main categories: informed and involved. And that obviously involves really listening and honoring choices that residents and per the residents, their families have choice and listen to them. And that includes things that include medications, vaccinations, transmission-based precautions. I know when I worked in acute care and even in some outbreaks, there was people that they flat out refused. And I know, to do have certain medications, vaccinations, or even transmission-based precautions. And so it was always a balance because medications and vaccinations, that's fine. But when it comes to some transmission-based precautions, when people refuse, now a lot of COVID regulations state, well, then those people can't be allowed in the facility. Previous to COVID, it was like, okay, well, how can we really, it was really up to the facility to decide how can we best address this, because there's some people who are not gonna go along with this, but we still need to find a way to make sure that we are protecting other residents. So that's still, that I think that's going to evolve as well as we move more into normalcy post-COVID. The other under informed and involved is, partners in all aspects of care and all levels. So obviously care planning, shift change, transfers, residents should be informed and involved in those types of aspects of their care. They have the right to have communication and choice. So accurate, unbiased, timely communication. For example, when there are infections in the facility, making sure that the information's out there, making sure that it's clear what the facility is doing to address that, and while respecting privacy. That's always an issue, is people want more, there's always they want more and more data, they want more and more information, but it's always, the facility has to find that thin line of making sure, yeah, we are being transparent and clear, but we also have to respect the the rights of the resident, making sure we're respecting their privacy and not disclosing too much information that is going to have that person identified. So that's, is always difficult. And then to plan and participate, residents have the right to plan to participate in shared decision-making and planning, delivery, and evaluation of services and programs. So, they do have the right to be involved in quality initiatives and see what is going on in the facility. All right, next slide, please. So another part is resident and family engagement. So you have rights and then engagement, and the role of engagement in infection prevention. So a major component of obviously person-centered infection prevention and preserving residents' right is engagement. Engagement by both with residents and family obviously creates an environment in which every resident or family can work as a partner to improve infection prevention. And we've seen this a lot, I think a lot more in acute care. There has been, of course, in nursing homes as well. That there's been plenty of studies that show when you do have engagement, increased engagement, you do have higher resident satisfaction, better clinical outcomes, and even higher staff satisfaction, because it isn't a monitoring situation where families and residents are monitoring people. It really is an attempt to make sure that there is a mutual partnership, and it's beneficial, and it is a partnership, so that it's not monitoring, it's again more of a mutual partnership. And that does, when you create that kind of environment, then it does lead to higher staff satisfaction. Next slide, please. So really, to have effective infection prevention, you really do have to have this, residents' rights. You have to respect residents' rights and consider this, and you have to have engagement. When you really think about these two components, that is really how you're going to have good person-centered infection prevention, and it's going to be effective. It's going to be more effective, especially in nursing facilities, because you do have limited staff that's not able to maybe take on some roles that maybe residents or families can take on in monitoring some of these quality aspects. Next slide, please. So advocacy, obviously very important. So again, engaging patients and the residents and family members as active partners in infection prevention, it really is a key strategy to reduce infections. Residents and their advocates can help identify any safety problems. They can be trained to be active team members to fight against preventable infections. They can also be part of infection prevention education. I've seen where you can include patients and families in order for them to develop skills, knowledge, and confidence to have active partners, so that they have the knowledge, they have the skills, they understand this, but also even to provide stories and provide information whenever staff is getting trained, so that people have a better idea, staff have a better idea of the resident and the family members' perspectives. So whenever you're thinking about your infection prevention plan, it really is important to ask, what is the resident's perspective, and how will we engage residents and their advocates as partners in this action step? How can we do that? And it's out there like a question, but it truly is. I think when you think of it this way, it does increase your ability to do more infection prevention control. And I mean, of course, this applies to any safety, but I think in particular right now in this climate that we're in post-COVID, I'm gonna say post-COVID, but now that we have the vaccine, there's still this interest in wanting to make sure we're preventing infections. And this is, I think, an opportunity, a good time to say, how are we going to structure our infection prevention plan so that not just for COVID, but all things moving forward, we're really getting the best bang for our buck when it comes to infection prevention. And I think when you think of this, what's the residents' perspectives? How are we going to engage residents and their families and their advocates to partner in these action steps in our plan? It's going to really, again, it's going to give the biggest impact on infection prevention. Next slide, please. So what are some, best practices for patient and family engagement? Care and quality communication, anything that has to do with shift changes with the resident and family engagement. This was a big push for a while for CMS. And it seems like it kind of, at least in my opinion, you guys know best, it seemed like that kind of fizzled out. But again, making sure that there's good residents have that right and it's respected, where they do have good information. They're informed of what's going on. Communication boards, huddles, care plans, all of those things can help communicate quality and infection prevention as well. And then QAA summary at resident and or family councils. This was actually, this is something that Jay had mentioned would be good to have. So I put it in here. So I know there's a lot of people who are, a lot of facilities I've spoken to, they're very hesitant to have somebody in their QAA committee, a city member that is a resident or family or an advocate, but maybe have somebody from QAA come and do a summary at a resident or family council. And then family presence and input. Infection prevention rounds with residents and or family council member or advisor. Maybe you can have a family member or resident who's a champ, so that they they are the person who is over the family or resident council, so that they get an idea of what happens during infection prevention rounding, or to even ask, is infection prevention rounding going on, and what does that entail? And again, another idea that Jay had mentioned is advisors on boards and improvement teams. So having a QA subgroup, so not directly on the committee, but a subgroup that has residents and family members as well. Engaging in education is a really good best practice. So opportunities for residents and family stories to be shared in education. I actually saw this when I was working a really big outbreak that had to do with multiple nursing facilities, and it was a multi-drug resistant organism, and they were having a lot of issues with compliance. But one of the things that happened, I think that was a turning point for the education, was whenever family members, they came and they spoke, families and residents came and spoke during the education about what the impact was to them and what this, what their worries and their concerns were. When they shared those stories, I think it really set the scene for really having the staff understand why it was important to take that education and to understand why it was important to implement it. So that was a really good way to do engagement and making sure that it really helped with education. Shared decision-making tools and teach backs is always good, especially when you involve residents and their families. And then education materials developed with the help of residents and with the help of family members. So again, I think this is something that we see, whenever we develop education materials, we think, oh, we definitely want to get the input of staff because they're the ones who's going to use it. So we need to make sure they get their input. But in a very similar way, need to think about this with residents, patients and their families as well. They need to be actively engaged in, getting at least some feedback if there's going to be educational materials. Is this something that they understand? Why is it important to them? What is something that could be emphasized in the education? All right, next slide, please. All right, so HRQ has this, this is something that they put out, patient and family engagement. And they talk about, this is obviously for all healthcare facilities, this is an ongoing issue. How do we change the culture to make sure that there is engagement? This is, I don't have to tell you guys, this is an ongoing thing, right? There's always time. How do you make time for really making this engagement and respecting rights is part of infection prevention? Make this part of your everyday work. Culture focus on a patient, how do we include, changing that culture? That is really huge because at least a lot of nursing facilities that I've been in, that is, I think even in acute care, because maybe in the mind of the providers, they know it's acute, this person, even if they're in the ICU, they know at some point they're going to leave and it's a very different environment. But so they're more likely to include patients. But I think whenever for nursing facilities, including engagement is very difficult because there does seem to be administrators and staff that feel like, hey, this is our job. This is what we do. We got it. We've handled it. We want you to do your own resident stuff, your activities and other things, but this is kind of our ballpark here. So this is, I think, probably the most difficult is really having that culture change. And then responsibility, who is responsible for infection prevention? Yes, of course, for regulatory reasons, it is the facility and the staff, but ultimately to have for the facility to be responsible, you have to think, who can I best work with to make sure that I am meeting my responsibility? And so that again goes back to the culture change of making sure that you are involving families, the residents, and ombudsmen who are the advocates for, for residents, to make sure that you are able to carry out those responsibilities in a more effective way. Next slide, please. So, so because we, of course, we have these barriers to engagement, what are some strategies to help nursing homes get started? So this is adapted from the HRQ. Again, they're more patient-centered and acute care. So when you think about nursing homes, there's these 4 strategies. The first strategy is work with resident and family councils and ombudsmen. So, how to identify, recruit, train, and work with councils and ombudsmen. How can we really involve them? Strategy 2 is communicating to improve quality. So ideas on communicating quality initiatives routinely. How is this done? Strategy 3 is shift change and report. So ways to enable safe handoff of care among staff, patients, family members. That there's rounds, things that that's I think shift change in particular is very difficult, in my opinion, in a nursing home compared to acute care, because there's just the staffing issues alone. So it makes it, this is I think of the strategies, this is probably the tougher one in my opinion. I'd love to hear what you guys think of the barriers to engagement. And then 4 is ideal transfers. So strategies to engage patients and family members in transition between facilities or even units. This is really important because when we see a lot of infections that happen, it really, many of them can go down to transfer. A patient was transferred here, a resident was transferred here, and we didn't know they had a certain infection. We didn't have the right information, or the resident knew and the patient and the families knew, but they didn't really communicate this to us. They didn't know if that was something they should communicate or how to communicate. So this is really important as well. The transfers in particular are very important because I have really seen this being the beginning of an outbreak in any facility. As somebody was transferred in with, and that communication, there was a gap in that transfer. All right, next slide, please. Okay, so overcoming barriers, obviously identify barriers unique to your culture, talking with staff just to find opportunities, barriers, challenges. Obviously senior leadership needs to be encouraged to make resident partnership a priority. And then of course, get assistance from your facility's resident advocate, your ombudsman. They can really help. I mean, that is what they are there to do. And they can help designate, and you can designate a resident family engagement champion. They can help you with this. And then develop action plans. And very importantly, because this is a huge undertaking, focus on small tests of change. So little things, just start with little things and then see how you can go from there. So, obviously changing culture is a big, huge undertaking. It can take, could take years. It depends on, what's going on with the facility, but, you want to focus on small tests of change, things that, you feel that, okay, let's begin with this and let's start with something small so that we can start slowly chipping away at making that culture change. And also because you don't want to take on something so big that it's going to ultimately lead in failure. And then you're like, oh, let's forget this initiative. I don't want to do this. This is too much. All right, next slide, please. So key points is there are many resources to help organizations improve resident and family engagement, but your ombudsman is really key. They really are key. This is training, as that I learned being an ombudsman when I went through the training, that this is one of the primary things that your ombudsman does, right? And then of course, residents and family members are essential partners in infection prevention. Most nursing facilities do not have the staff, do not have a designated infection prevention staff. So this is a way to, when you have resident family members are engaged and they're partners in this is a way to help you really monitor and evaluate any potential issues and making sure that it's being addressed before things get out of hand because there wasn't that engagement and communication. And of course, infection prevention education should include residents. That's not residents and their families, and that's not just their education, but also in the education of staff, so they better understand the perspectives of residents and family members. And then the resident's perspective should be integrated into infection prevention efforts. And expanding resident family engagement practices, of course, requires culture change because engagement is difficult. There are many challenges, but ultimately it will lead to more successful outcomes. All right, next slide. All right, so I thought we'd go through a little case study going through applying resident-centered, person-centered infection prevention. So this is actually a case study from the Ombudsman annual review. So this was, there was a resident's son who's visiting his mother, and he sees that staff's just not wearing masks at all, or they're just wearing them incorrectly, right? So they're wearing them below their nose, their mouth, they're just, so he complained about this problem to the facility administrator, the DON, and even the facility's corporate office. And then he just continued to see issues with mask wearing. This was just a problem. Next slide. So when you think about which residents' rights do we need to consider in this scenario, when we're thinking about their rights, what is it that we need to think about? Because this is where, again, when we think about resident-centered, patient-centered, person-centered infection prevention, you have to think of residents' rights as well as engagement. Next slide. So again, we have to think of these three main categories: being informed and involved, having communication choice, and planning to participate. Obviously, listening and honor to choices, listen to resident family members' concerns, and choice to go to different levels of management. This for many facilities, this is a problem. Like, hey, you already went to the DON, you went to the administrator, and now you're going to the corporate office. It's something that you have to consider. That is, they do have the right to be able to do this because they want to be listened to. Partner in all aspects of care in all levels, the right to be informed of current requirements regarding face masks for staff. What are those? Have communication choice, so accurate, unbiased, timely communication. So timely communication regarding facility plan to address the issue and acknowledge the issue. This person and the family member and the resident felt like, hey, this is not timely. They're not addressing our concerns. So we went to the DON. Didn't seem like anything timely was happening. We went to the facility administrator, still nothing. We went to corporate, and still we felt like this wasn't being addressed. And then plan and participate, so shared decision-making and planning, delivery, and evaluation of services and programs. So improvement quality initiatives, right? So educational efforts, rounding, facility compliance monitoring. This is something that residents and family members can be involved with and should be involved with if you're going to really make change in these areas. Next slide, please. So then in this scenario, what barriers to resident and family engagement exist in this scenario, and how could they really be addressed? Next slide, please. So, we did talk about this culture. Again, we have to kind of come back to this, how, we want to make sure that we're thinking about, what are the barriers to culture change in our facility that is going to keep us from engaging family members and their residents and their advocates. Next slide. Because ultimately, again, with every step, you really do want to consider what is the resident's perspective? How will we engage residents and their advocates as partners in this action step? So the facility administrator, the DON, even corporate office, knowing that this was a complaint, this was an issue, should then begin thinking, what are some quality initiatives that we can institute? And when we institute these quality initiatives, how can we think of the resident's perspective? And then how can we really engage the residents and their advocates in these action steps to really working with mask compliance? So again, they developed an action plan. They focused on small tested change because, again, culture can be very difficult to change. So strategy one, they worked with resident and family councils and ombudsmen. So the facility ombudsman provided resident family information regarding regulatory requirements and training requirements. The facility ombudsman provided resources to facility for PPE training and engagement of residents for staff. And then strategy two, communicating to improve quality. So a QI initiative was implemented called Masks Matter, and it taught was taught to staff, residents, and family to point to visual reminders. So they learned about, how to wear PPE correctly, what were the regulatory requirements, but they had these buttons and these posters. So when they saw somebody not wearing masks, they would remind them, hey, masks matter. And it was just a quick reminder, masks matter. So when they saw somebody that didn't have their mask or wasn't using it properly, they would be like, hey, masks matter. It was just something to point to, something that was a visual reminder. And it made it not so it made it so that people weren't on the defensive, because everybody knew there was this initiative that they were pushing, the Mask Matters initiative. So it wasn't like, oh, are you just trying to call me out for not doing my mask right? It was like, hey, this is something we're all doing. We're all committed to making sure that we're all doing this. You're helping me do it better. I'm going to help you do it better. And it was again a partnership because of this initiative, and it made it a safe environment. And there was post training. There were quality improvement rounds of PPE usage conducted, and information was placed. This was conducted by the facility, and there was a resident council advisor who helped with this. And they actually put up huddle boards, and the huddle boards included monitoring mask compliance. Like, hey, in this unit, this is how we're doing. This is how we're doing with PPE compliance. And the resident council helped design these huddle boards. Like, this is the information they wanted to see too. So that was out there. And since it was on a huddle board out in the hall, the residents could see it, the family members can see it. They knew that they were involved in helping to put what information should be on there, and they could see the progress. They saw that, yeah, every time that because they did it weekly, every time they monitored this compliance, it got better. And so they were able to see that. And they also did, they always do rewards, like, hey, this unit, this is what their huddle board showing. And so this week, whoever has the most improvement in this or that, they got a little prize. And those prizes and those recognitions were done by the resident councils. And then shift change and report. So one of the things that they did implement was during shift change and handoff, they included a PPE check and a reminder. So, hey, just reminder, this is something, make sure by their mask, they would put it as part of their shift change. So it was always a constant reminder. All right. So, this is what they implemented. 1 month later, the Sun and the resident stated staff consistently wore masks over mouths and noses. And of course, not only did the PPE compliance improve, but also hand hygiene practices improved as well. And they also implemented, this was a new way to receive positive feedback and constructive criticism on compliance that, again, wasn't about monitoring. It wasn't about shaming anybody or shaming certain people or units. It was really about how can we work together to improve quality, improve infection prevention here. And it really helped increase staff, resident, family understanding of what it takes. It's not, what were some barriers? What were some issues? And how did we overcome this? And it made them all partners in increasing mask compliance. All right. That is it. Does anybody have any questions?